What is gastroesophageal reflux disease?
Well, it's all kind of in the name. So gastroesophageal, meaning that it has something to do with the stomach and something to do with the esophagus, the tube that attaches your mouth to your stomach. And then reflux, meaning like something is coming out of the stomach and going into the esophagus. So we're talking about stomach acid. So stomach acid is very, very important. Helps you digest your food, kills bacteria, kills things that you swallow that you're not supposed to swallow. And then, but it's acid, right? And so the lining of the esophagus is very sensitive. And so when that acid gets up in there, it's very irritating, gives you the symptoms that you know and love. And that's all supposed to be prevented by some kind of mechanical structures where the esophagus meets the stomach. There's something called the lower esophageal sphincter. I'm sure you've heard of the word sphincter. We have them in other places in our body.
I'm thinking kind of down towards your ass, but anyway.
Yeah, I wasn't going to go there, but you did. That's fine. Okay, so actually, where the esophagus meets the stomach, it's not what we call a true sphincter. It's not a band of muscle, but it has the function of a sphincter. Okay, basically a circular valve. Something that opens and closes. Okay.
Okay.
So and then there's the way that the top of the stomach sits. There's kind of an angle there, and so basically the way everything, when it sits just right, and there's an interaction with your diaphragm, because your esophagus comes down through your muscular diaphragm, which is this dome of muscle that helps you breathe. Anyway, when it's all working correctly, the acid stays where it's supposed to, and it doesn't go in the esophagus. When that gets disturbed in some way, then the acid starts creeping back up into the esophagus, and you get lots of problems. So, anyway, there's lots of those. You get the heartburn. That's the classic symptom. So if you're feeling heartburn, that's what's happening. The acid's going where it's not supposed to be. And then, but you also get pain. You can just get pain, aside from the heartburn. And then you can have difficulty swallowing. You can have regurgitation of food. Can really interfere with your sleep. I mean, there's just all, kind of a, whole host of symptoms that you can have associated with this.
Okay. Thanks for the explanation.
Yeah.
I actually understand that. I don't suffer from GERD, but I definitely get the concept. So I guess everything's working fine, and in my sphincter and all that acid reflux and all that kind of stuff.
So here we have a picture, a green arrow. In medicine, acid is always depicted as green. It's just a convention. And acid or bile. So as it says at the top there, this is hiatal hernia causing GERD. These are pictures from a textbook that's real nice that I like to use because it has great pictures. And so what you see here is the piece of the stomach kind of sneaking up through the diaphragm. And the whole point of this is that the acid is going up where it's not supposed to be, the kind of yellow part there. And then it's showing the guy laying on the pillow, and in the top, it's showing him kind of laying flat, and in the bottom, he's propped up on the pillow, and then the acid goes back in the stomach. So this is a very common experience that people have when they have GERD or hiatal hernia or an acid disturbance of some sort. They'll start sleeping on 2 pillows, then they'll sleep on 3 pillows, and then they'll buy risers for their bed, and they'll tilt up their whole bed. Okay, and just to get some relief so they can get some sleep. So that's kind of what that's depicting there. And if you want to go down to the next one, Craig. So these are some gross pictures. So basically what this is showing is when the acid is going up into the esophagus, it says right there, peptic esophagitis. So anytime you see the ending itis, it just means inflammation. Okay, and so basically it's just showing the acid inflaming the lower esophagus. And if you scroll down a little bit, it shows that chronic inflammation. And so And then, so there's a couple. So here we can get into some secondaries, if that's all right. Can I do that?
Yeah, let's go for it.
All right, great. Yeah. So, the most horrible possible result of GERD and why you should get it treated and not just ignore it is that it can cause cancer. Okay, so it's an adenocarcinoma. That's just you don't need to know what that means. It's just a fancy word for cancer. And then, but it causes cancer in the esophagus, because the stomach is supposed to have acid, but the esophagus isn't, and it gets real inflamed. And when tissues in the body are inflamed over and over and over again for years and decades on end, they develop cancer. So, so there's an intermediate step. It's called Barrett's esophagus. You may or may not have heard of that. That's something that they would find if they stick a scope down into your throat. And any case, so if you have GERD and you develop cancer in your esophagus, that's a secondary.
So, what is the best test? You mentioned a scope. Like, what's the best test to see what's going on down there? Whether it's
the main and most common test is a scope, because nowadays they're very safe to do, and so a GI doctor, they say "I love you" by scoping you. Okay, yeah, that's a every specialty has a way that they say "I love you." Okay, so that when they can directly visualize the tissues and then take a little biopsy and then send that to the pathologist in the basement of the hospital, that really will tell you exactly what's going on. Some other tests would be like it's traditionally known as a barium swallow. You can also call it an esophagram. It's basically a video X-ray, and they have you swallow some contrast material, and they watch to see if it goes in the stomach and then comes back out up into the esophagus. Okay. There's another test called pH imetry. Okay. It's basically you have to stick this probe thing down your throat, and it measures the pH in your esophagus and over the course of like a day. Sometimes it's necessary to like really define, like somebody might have a normal scope or they have a normal X-ray, but they have terrible symptoms.
pH tests. I'm actually doing one of those because I'm working on my lawn. Are they similar at all? Is the pH test on my lawn and in your body?
Or your pool or whatever. Okay. I don't know if you have a pool, but
so a pH test is a pH test. It could be in your pool, it could be in lawn, it could be in your body.
Acid, base. Yeah, exactly. Yeah, that's right.
All right, let's scroll down to I don't think we have any more images. Let's talk about how this is rated.
Yeah. So this gets into some good stuff here. So there's that diagnostic code 7346. Okay, so we'll start at the top. So the people that get a 60% rating for GERD, I mean, gosh, this basically dominates their life. Okay, they have symptoms of pain, vomiting. So not just like a little bit of regurgitation of food into the back of their mouth, but they're like throwing up their whole meal. Okay. Material weight loss, meaning like it's like serious. That's what the word material means there. Hematemesis or hematemesis. Hematemesis is what I say. Emesis is throwing up. Hema is blood. So not just throwing up, but throwing up blood. Okay. Melena, that's blood in your stool. Okay. So, and then moderate anemia, that's like when your red blood cell count is low. Okay. And then
just, I don't want to cut in too much, but there's a couple words that I like to clarify. And it says material weight loss and right. And then, so you have to have material weight loss and two of those words that I can't describe, right. So there's the and or statement in here as well.
So here, the way I would interpret this reading, which I believe is correct, is that you're having hematemesis or melena. Okay, because those are blood where there's not supposed to be blood. You're throwing it up, or you have it in your stool. Okay, so what they're saying is you have to have weight loss and one of these blood things.
Okay, thanks for clearing that up.
Yeah, absolutely. and then also have moderate anemia. So as you can see, this is a pretty high bar to get this 60% rating. I mean, those all sound like horrible things, and they are. So, so anyway, and then it gives you a semicolon and says all of those things, or other symptom combinations productive of severe impairment of health. I have never been able to find a definition of severe impairment of health. Looked in the M21-1. If there's some brilliant veteran out there who knows how to navigate that document better than I do, and you can find a definition of that, have at it. Please let me know. So
it sounds like a catch-all. But it's a catch-all that needs to be defined and most likely argued by a lawyer in a court of law kind of a deal.
Yeah, exactly. So, but as you can gather, it's got to be severe, basically on the same level as like the first section. Okay, so that's 60%. In my experience, this is rather rare. Okay, so if you have it in your mind to be going after a 60% rating, you know, you've got to have some pretty bad symptoms. Okay. So, all right. So going into the next one. So we've got the 30% rating. In my opinion, this is actually pretty common. So, okay. So persistently recurrent. So this kind of seems redundant to me, and it is a little bit redundant. Persistently recurrent. Anyway, epigastric distress, which just means you have a, you know, funny feeling in your upper stomach area. Epigastric just means above the stomach. And then with dysphagia, so that's trouble swallowing, okay? Pyrosis, fancy word for heartburn. Regurgitation, that's food coming back up into the back of your mouth without vomiting, okay? And then accompanied by pain in one of these three places: substernal, which would be the most common, arm, or shoulder. So why, if your stomach is putting acid in your esophagus, would your arm or shoulder hurt? This is something we call referred pain. So it's just you feel the pain in one part of your body, but the problem is somewhere else, just to trick you. Okay. All right. So and then it has this catch-all statement: productive of considerable impairment of health, contrasting with severe impairment of health in the 60% rating. Okay, so this is a long kind of laundry list of signs and symptoms, and you have to have all of them. Okay, and so, so these people are pretty miserable. Okay, but they're not the 60% rating, and then the 10% rating is just kind of mild. Okay.
All right, let's take a look at a DBQ and kind of walk through that a little bit. How's that sound?
Let's do it. This is my wheelhouse right here, the DBQs.
All right. So, and a DBQ is a Disability Benefits Questionnaire. This one's for GERD, hiatal hernia.
So evidence review, if you mark, or if your doctor marks no records were reviewed, that's bad. Okay.
That's kind of like you wasted. That's it.
Exactly.
You wasted your money, your time.
Yes. So this is, in my mind, a little tricky thing from the VA. Like, okay, we're going to set this trap that if anybody marks this box or circle, then, you know, we're going to reject their DBQ. So records review, you got to put something. Okay. So I, at least when I do these, put this first sentence that I reviewed all the relevant records. Okay. that at least gets something in there, because sometimes I don't review a whole lot of records if it's not necessary, you know. But if it is necessary, or the veteran happens to give me a whole pile of records, then I will put in, you know, for example, reviewed their STRs and the prior C&P exams and their VA treatment records and whatever. Okay, the more the better. Okay, because this is what the C&P examiners do. For some strange reason, they are obsessed on their own DBQs with like putting a whole bunch of stuff in that block. Okay, so moving on to page 2, there's just a yes, no. Do they have something? We're doing a DBQ on GERD. It could be, you can do this for other things. I have found that it's, this ICD code is not really that important. the date of diagnosis, this can be important because you don't want it to conflict with something else in your record. Okay. Like if you're, for example, going for direct service connection, okay, meaning that you had this disease in service, okay, and you served from 2000 to 2010. Well, you don't want the diagnosis date to be 2021, okay, because that's not going to help you with your case for direct service connection for the GERD that you had in 2008, okay? So pay attention to that. Okay, so
but for a secondary, whole different ball game. We'll get into that a little bit more. So
yeah, less important. You know, well, except that it needs to be after the other thing.
Correct.
You don't want
right. If you're filing it secondary to something, right, you can't have your secondary diagnosis predating your initial thing that you're trying to hook it onto.
Unless you served in the time machine unit, which is super secret, right? Yeah.
Maybe that's something we'll find out in the Space Force.
yeah. All right. So block 1C, that's if like that would be, so talking about secondaries, that would be a block 1C where you would put like the thing that caused the disease, like so whatever led to your GERD. Okay. So describe the history. This is another one that's a little bit tricky. So you got to put something, okay? Have your doctor put something, I mean. And the C&P examiners get all wrapped up in like putting all kinds of stuff in this block. And once again, you know, in my opinion, it's kind of irrelevant. Like you're just assessing the severity of the disease now, like how it is now. Like, okay, so, I don't know. This can be useful for you if you can get the doctor to say, it's been this bad for this long, you know? And, but I just put a little blurb there, like supporting direct service connections. Sometimes the doctor will put like a little nexus statement in this history section. You see that sometimes. I mean, personally, I do a more explicit nexus letter. Okay, I don't rely on a little one sentence in the DBQ. But so this history thing, something has to be there. That's my point. You don't want your DBQ rejected as not being sufficient for rating purposes just because, you know, something didn't get put in there that they asked for. So that's just something I see a lot, so I put it on there as an example. Okay, so signs and symptoms. Here's where we get into the meat, okay, and potatoes of the DBQ, okay, the check boxes. Okay. So first of all, they ask a yes, no. Does the veteran have any signs or symptoms? Well, obviously yes, because you're filling out the DBQ.
Well, actually, it's not obvious. If you put no, that's another way to kill your
there you go. There's a trap DBQ. Right there. Yeah. Okay, so so those first two check boxes, if you recall the rating schedule, the first checkbox is for 30%. The second checkbox is for 60%. Okay, so here's a little trap, right? So if your doctor is like, how the heck do I fill this thing out? Like, what do these mean? These look like the same thing to me, considerable and severe. So, you know, you just inform them like, hey, you know, that first checkbox is for a 30% rating. To me, it's okay for the doctor to know the ramifications of the box that they're checking. So in any case, it's going to be difficult for you to get that 30% rating if that first box isn't checked. Okay, that's the point.
Yep.
All right. So third is another. So here's another little trap: boxes 3 and 4, persistently recurrent versus infrequent. Okay. So if you're getting your doctor to fill this out, they may, in their mind, be thinking, you know, well, it's infrequent because they're on meds. You got to remind them, how am I when I don't have my meds? You know, do I fall in that persistently recurrent, which is not defined, okay? It's open to interpretation. So, okay. So those are the first 4 boxes are 2 little traps. Okay. So getting into the actual symptoms, so the ones for the 30% rating, you have to have the dysphagia, the difficulty swallowing, okay? And this is basically like it hurts to swallow when you're having a bad GERD attack. Okay, that's basically what that is. All right, pyrosis is the heartburn. Reflux is like fluids coming up. Regurgitation is food coming up. So like difference between liquids and solids. Okay, and then it says the pain, and then it gives you the 3 options: the substernal, arm, or shoulder. One of them has to be checked. You might have all 3. That's fine. Okay, so then we got sleep disturbance. They ask this question in a funny way. They ask like up to 4 times a year. So this is to me, this is worded kind of funny. But so if somebody's having sleep problems, generally it's like way more than 4 times a year. It's like every night. So I just mark 4 or more. And then the duration is generally just for the night. So I mark less than 1 day. So it's a little confusing, but
well, I have another kind of add-on just to make this even more complicated than it needs to be. So this is talking about sleep disturbances. I have a rating for insomnia inside of mental health, and then I also suffer from sleep apnea. So would there be any kind of pyramiding going on here to complicate things?
I don't think so. The way that the VA rates insomnia and sleep apnea, so insomnia is rated, as you mentioned, as a mental health condition. So it's kind of, included in that umbrella, okay? And then sleep apnea, is quite different from insomnia. Sleep apnea is actually rated as a respiratory disorder, because it is. And then this sleep disturbance is not even included in the rating schedule for GERD. So my only answer to that is that they do have those umbrella catch-alls that like, okay, maybe this person doesn't have these other things, but they do have such terrible sleep disturbance that it gives them a severe impairment of health.
Gotcha.
Okay, material weight loss. So they give you like a baseline weight and a current weight to put in there. And then, as I said, the 60% rating is kind of rare. I generally don't even, I don't think I've ever written anybody up for 60%. So that takes a little work right there, because it tells you there, baseline weight is the average weight for the 2-year period preceding the onset of the disease. Well, then how the heck are you going to get that information? I mean, and you'd have to like dig through records or just go off the veteran's memory. It's kind of silly. So that's a little bit difficult to prove, but that's what they ask for. So I just leave that unchecked usually. Gotcha. Because I'm not going to that 60%. Okay, so here we get into something that's not in the rating schedule, kind of like the sleep thing, is the nausea. And so a lot of people get nausea with GERD. Generally, I put that 4 or more, less than 1 day. Generally, people with GERD are not getting nausea that persists, for days and days and days. That's kind of rare. Okay, vomiting. This would be different from the regurgitation because the food is actually coming out of your mouth. Some people with GERD get vomiting. If you have it, or if the veteran has it, I check it. And I think if I remember correctly, looking at the So that's they asked specifically about the vomiting because that's in that 60% rating. So anyway, so you got to have that if you're going after the 60%. The hematemesis is the throwing up blood, kind of rare nowadays because we actually treat this disease rather effectively with something called the proton pump inhibitor. I mentioned that in the medication list: the pantoprazole, the esomeprazole, the omeprazole, all the Nexium, basically the purple pill. Okay, so melena is blood in your stool. And just if you're wondering, like, oh, how do I know if I have blood in my stool? I'll get gross here for a second. If you have bright red blood in your stool, you recognize that as blood. Blood coming from the stomach actually gets processed and digested in your GI tract, and it comes out as a black tarry substance, okay? So if you have that, you have melena, okay? So, that's a classic sign of upper GI bleeding, okay? Because the blood's getting digested. Okay, I'm done with the gross part. Okay, so Anyway, and then we talked a little bit earlier about what problems GERD can cause. We talked about stricture, spasm, diverticula. That's a little outpouching. So generally, you know, nowadays, not real common for people to have these because it gets treated early. But if you do, then that needs to be marked. Some people do get that. Okay, this is on all DBQs. The other findings block. Okay, because not everybody fits in the perfect peg hole that the DBQ is trying to have all the check boxes for. So this can be useful if you're most people are horses, okay? But if you're a zebra or a unicorn, okay, then you can have your special symptoms listed in this box. This is on every DBQ. If you have any scars associated with this, so you're probably wondering, how could I have a scar associated with my GERD? Well, you may have had surgery for your severe GERD, okay? And so there's two surgeries that are done for GERD. One's called a Nissen fundoplication, okay? And that's, I'm not going to explain the surgery, but they basically go in and fix those structural problems that I was talking about earlier. And then if you have really bad GERD, then you can get actually a gastric bypass, okay? Which might sound like a, really drastic action, but it is done. Some people they're that miserable from GERD. So anyway, so you would have a scar from that surgery, and it might be painful or unstable, as it lists right there in the DBQ. And so you can get a rating for that. Okay. And if you had a Nissen fundoplication, that's most commonly done laparoscopically. So you would actually have like 3 scars, okay, the little punch holes. Okay. And then there's another place for comments about scars. And then we get into the diagnostic testing. And I mentioned a couple here just as an example. The upper endoscopy would be the scope. You got to have the doctor put something in the results section, and it's fine just to put like, yeah, I didn't find cancer, just something. Okay. So if you're taking this to your doctor, you might want to have the result of these studies there so that they can reference them and fill out the DBQ for you. Okay. So, don't expect the doctor who is doing this for you to do all of the work. Do a little bit of work for you. Okay. So
well, if you're going to do this stuff, it's best to make sure that these reports are in the endoscopy and stuff are filed with your claim, so
Absolutely.
they have it before them, not at the C&P exam. Excuse me, I know I only have 40 seconds for a C&P exam. Can you take a look at this? You want to do that and load it up front.
I hear you. Yeah, I agree with everything you just said. So, and then the upper GI study, that's that one I was talking about, the swallow study. And then generally, you're not getting into MRIs and CTs for this stuff. If you have it, put it in there. They talk about biopsies, so that would be on the scope. And that pHimetry that I was mentioning, that would fall in that other category. Okay, so laboratory testing. Why are they talking about laboratory testing? Well, if you remember back to the 60% rating, they talked about anemia. Okay, well, that falls under this CBC thing, complete blood count. Okay, and then it mentions Helicobacter pylori. What is that? Sounds like a demon. It's a bacteria. Okay, and if you grew up out in the country like I did, and you drink well water growing up, you probably have this bacteria colonized in the lining of your stomach. Often, it's very common, okay? And so that has a relationship with GERD and like acid status in the stomach and stuff. So this little bacteria can survive the acid. Okay, so anyway, so they ask about that. And then other, just in case there's anything else. Okay, and then they give you another block for like anything else. Okay, if you had some sort of unicorn test, like horn length or something. I don't know. Okay.
horn length, shininess, and color.
Okay, and then they say, does this condition impact your ability to work? Very common for C&P examiners to mark no and put nothing. Okay, so I always put something here. Okay. because you might in 5 to 10 years apply for TDIU. Well, if you have a whole pile of C&P exams or private DBQs that say that there's absolutely no interference with your ability to work based on your disabilities. Okay, and then the remarks section, you can put whatever you want. So here's what I put in the remarks section when I do this. So I do a little introduction about myself and who I am and what I do. I state again that it was an in-person exam and that the person traveled. And then I include a statement about the credibility of the veteran, because that's sometimes an issue in these cases, especially if I'm basing a lot of what I'm saying on their own history that they're giving me. Well, I put in a statement like, I'm a doctor. I can assess people's credibility. Like, doctors are kind of like human lie detectors. They know when clients and patients and veterans are lying to them. So I explicitly say that. So, and then I'm a veteran myself. So I just out of the blue say that I have expertise in military and medical matters. So, okay. So, all right. Date of diagnosis. This is something that I put on all my DBQs, and it just kind of explains that, kind of what I was talking about earlier, that you want the date to be like kind of obviously matching up with reality, but at the same time, you don't want the doctor who's filling this out to accidentally ruin your claim.
If you need to appeal your VA claim, check out Hill and Ponton at hillandponton.com. See if they can help you out. Also, if you're at Camp Lejeune between 53 and 87, you may be eligible for additional benefits. Links for both of those are in the description. Don't forget to sign up for my boot camp if you want to learn more about my process, which is the VA claims process. You're going to need medical evidence to win your VA claim. If you're missing a diagnosis, severity of your symptoms, or a nexus, and your doctor won't do it for you, send an email to Second Strata and see if they can help you with your missing medical evidence.